So good morning, everybody. My name is Jeanette Wolf. I'm a professor at UMass Medical School, Bay State. I am a frontline emergency medicine worker, and my area of passion is sex and gender. So I was very fortunate to lead with other amazing team members this Thematic Group 2, Therapeutics and Diagnostics. We are really looking at the research and development pipeline and how to ensure that this are developed through a sex and gender lens. So besides myself, the other co-leads were Evelyn Bishop and Bernadette Adagam-Awankam. And I really want to give an enormous shout out to the people behind the scenes. Mariam Romani and especially Lavanya Vijayasingham were instrumental in getting this going. I would encourage everybody, because this, compared to all the other thematic groups, I think was a little bit intimidating to people to participate, because I think the gist was that they had to have a more biological sex and gender research background. And I would really love for this to go out to more people so that we embrace people who are doing this research, but also embrace their voices to help transmit this information to the broader scientific community so we do best science in 2021 and forward. So can you go to the next slide, please? So this was our group. What we did is we had the BuzzBoard dashboard where we started conversations, we came up with themes, and then questions were developed and evolved from these thematic groups. So overall, we had 23 contributors. There were 4 evolving drafts. The long list of the discussions were distilled down to, excuse me, to 42 research questions. We developed 4 characteristics of themes, and then we have now sent the survey out, and thus far we've gotten 23 survey responses. Next slide. So here are the top 10 in our thematic group. And for those of you who do this sex and gender research, some of these are not groundbreaking, amazing ideas. They're just ideas that are not being adopted and that are based in science, and that we need to figure out how we can spread to the scientists of the world so we produce better science for our patients. So these are the top 10. And to remind people, there are 2 scores here. The impact score is a combination of health equity and gender. The urgency score is looking at 3 different categories as to we need to do this right now versus this should be part of our long-term plan. So the impact score is ranked from 1 to 4, and the urgency score is ranked from 1 to 3. So these top 10 are a combined impact score that looks at health equity and gender lens. So the top one, not surprising, is how can we bring more pregnant and lactating females into phase 3 and phase 4 studies. As we know, those of us who have looked into this research, pregnant and lactating women have often been taboo for any sort of R&D in pharmaceuticals. And yet this is a perfect poster child to make us all recognize that pregnant and lactating females actually get COVID. And we need to come up with themes to help them survive COVID. Number 2 is what is the extent of enrollment and participation of women in ongoing and completed COVID-19 clinical trials across various sites and countries. This talks to the importance of how we enroll women into trials, because the challenges of getting women to participate in research trials are actually slightly different than the challenges of men. You need to think about work, you need to think about childcare, and groups who are doing this research need to put this into their thought process. Number 3, does safety, efficacy, optimal dosing regimen, and protective duration of the different COVID vaccines different in pregnant, lactating women and their fetuses and infants? This again goes back to question number 1. We need more information so we can guide these women for the appropriate things for their bodies. Number 4, in what way are sex and gender related variables integrated into national and global vaccine safety surveillance systems? How do we know who gets side effects and what are their intersections between sex, gender, and race? Next slide, please. The next question, does safety, efficacy, and optimal dosing of therapeutic interventions for COVID-19 and post-COVID conditions differ by sex, age, and race? So these next 2 questions are basically looking at the same thing. One is looking about therapeutic interventions and the other is looking about vaccines. Again, coming back to the intersectionality and the fact that we need more data than just dividing things into age, or sex. We need to consider the intersectionality of sex, age, and race. And there's some great work done by the Gender Sci Lab at Harvard that in America, we have shown that even though globally we know that males are more likely to die from COVID-19, if you look at the intersectionality of race and COVID in the United States, in at least 2 of the states of Michigan and Georgia, Black women had a much higher mortality rate than white men. So it's not enough to say, this male, this female, we need to get into the granular data of what are the characteristics of those males and females. The next question, how do the different aspects of human biology contribute to sex differences in pharmacokinetics, safety, and efficacy of COVID-19 therapeutics and vaccines? This is really making sure that the basic science that is continuing to evolve gets into the pipeline of research development. If you look at hormones right now, there are studies that block testosterone and other studies that give testosterone. This should be a basic science immunology question that we answered a long time ago. There are still tremendous gaps in the basic science, and we need to fill those gaps to be able to move forward to develop better drugs. Next question. This really deals on emergency use. How can we develop international standards and templates, including emergency use vaccine and therapeutic products during pandemics to be adapted to incorporate sex and gender in the evaluation of therapeutic safety, efficacy, and product registration? How can we get it into all these different areas of the pipeline so nobody's surprised after the fact when we discover these huge sex and gender differences that were there all along? Next slide, please. And then the last 2 questions is how can we get people to adopt better sex and gender design and analysis in their studies? There are already some great guidelines out there. How do we get them integrated into people who are doing mainstream research? And then the final question is, does safety, efficacy, and optimal dosing regimes of different therapeutic interventions for COVID-19 and post-COVID conditions differ in pregnant and lactating women, in their fetuses, and infants and toddlers? Again, this goes to the gap of what we need to know. We need to know, interestingly enough, we stopped these questions in May, and now that boosters are coming to the global forefront, there are a whole bunch of questions that we realize very quickly that we need to answer. Who has long-lasting immunity? Do we need the same dose? Do females need to be boosted at the same dose at the same time frame? Does that change depending on their age? So there are so many questions that we have the opportunity right now in this global pandemic because of the huge numbers of people involved that I hope we collect so that we can all do better science. Thank you very much.
Thank you so much, Jeanette. So I'm going to, in the spirit of time, I'm just going to hand over to Shirin, who can provide some insights and some recommendations on how we move forward. You know, as Jeanette already said, you know, there have obviously been some gaps. We had to stop somewhere. We can't keep going, so we had to stop somewhere. And you know, what are the things that we are perhaps not picking up at this stage? What are the things that we can do to sort of merge with what you have recommended through the paper as well? And how do we sort of, you know, approach new stakeholders who are not at our table yet? And how do we drive responses? As you can see, there's only a few people here in a group of 100. We've only managed to get about less than 10 people interested. So, and this is also the nature of the response rate for this particular group. So as Jeanette pointed out, I think, you know, the nature of the group speaks primarily to a very specialist crowd. So how do we get that specialist crowd? How do we get them in? I think we've got most of the gender experts, the sex and gender experts, maybe not, but how do we also attract mainstream health experts who may not work on sex and gender? How do we bring them to the table? And especially now that we've got Dr. Anna Maria with us, so how do we make that linkage? How do we sort of, you know, attach to the big mainstream work that they're doing? So over to you.
Great. Thank you so much. And thank you so much, Janet. First of all, it's like music to my ears listening to you. And while I think we were writing the paper that we recently published, maybe a little bit in parallel to this kind of stream of work, the result just reflects, how much these gaps have been a persistent gap in the field. And I think COVID-19 is really bringing the urgency to address these long waiting kind of science and gender gaps in the science. Just before we start, I just want to make a full disclosure that, as Lavanya mentioned, I'm wearing a couple of hats, and today I'm wearing my hat as a technical consultant on gender at WHO. However, all my opinions and statements are mine, and they are not necessarily representing WHO as an organization. I'm also in parallel a senior researcher at the Graduate Institute of International and Development Studies, affiliated both with the Global Health Center and the Gender Center, and the founding president of Gendro. So just for the sake of disclosure. And going back to the priorities that Janet kind of really presented, again, I think this really reflects the questions and the issues that a larger community of women's health advocates and gender and health experts have been calling for a long time. And it's really nice to see those demands reiterated and bring it back to life. And also, I think COVID really brings an urgency to the issues. Conversations around testing and developing effective and safe therapeutics and vaccines among pregnant and lactating women have been going on for a while. But again, as we see in the COVID-19 field, it is really an issue of really urgency. And it's really important to also make sure that we are kind of linking conversations that are going on in parallel. There are a whole stream of work that are working around inclusion of pregnant women and lactating women in clinical trials, including in the field of HIV with regard to HIV vaccine and antiretrovirals. And I think it's really important and critical to bring these synergies and accelerate kind of progress towards this end. I really want to kind of how sex as a biological variable can influence immunogenicity, pharmacodynamics, pharmacokinetics, but not enough, not sufficiently, and not across all disease areas. And I think their engagement and providing more evidence and insight will be really critical in order to make sure that we can develop interventions, diagnostic, therapeutics, and vaccines that are actually based on those knowledge and evidence. And it also helps us to ask the right questions and design clinical trials that can really answer those questions and really provide the answer. I want to also kind of acknowledge that we have done a lot of progress. I mean, looking at some data around women's participation in clinical trials, it has improved over the years. We have also kind of seen that more and more funding agencies and research funding grant agencies are calling for or encouraging, or some of them requiring, inclusion of sex and gender in funding grant proposals. The SAGER guidelines are being kind of an impressive uptake by journals and publishers. But again, despite all of this progress, we still see that the implementation of these policies are lagging behind. And I think that's where we really need to kind of realize that this is everybody's business. It's good to have all of these policies in place and those progresses, but it's up to every single one of us and all the gatekeepers in the entire health research and biomedical research ecosystem to be held accountable, from research funding agencies to ethics committees, regulatory agencies. And I think that's what we have really tried to outline in our paper, which is particularly focusing on COVID-19 vaccines, but in fact, it actually applies to all kind of health research across disease areas, and whether vaccines or therapeutics, that we really need to engage and make sure that these dimensions are taken into account from a very early stage, from the basic science, by the ethics committees, by the funding agencies, by the researcher when they're designing the research, when they're collecting the data, when they're doing the analysis and reporting, and so on and so forth, including by WHO SAGE members, for example, and other scientific community members, to really ask those questions and making sure that those conversations are being held and we are asking the right questions to really try to push the agenda forward. But again, commitment must also come together with investment. And we have seen that over and over again, that there are great efforts and great commitments on paper, but when it comes to providing funding to move that research agenda forward, that's where we are also failing, that we can't just do research based on, good intentions. That we really need the more capacity, more capacity building of, again, researchers, basic science researchers, health researchers, broader, as well as dedicated funding towards research to really address the priorities that you have identified, as well as the gaps, and really mainstreaming across the research, across disciplines. So I'll stop there just to open up for conversation with the other group members.
So Shirin, I have a follow-up question. You mentioned a very important word there, resource mobilization, funding. What do we do next? Even with this agenda, I mean, yes, all as Jeanette pointed out, it's not, it's not new, it's not rocket science. This is what we've been advocating for a very long time. It's, perhaps COVID's been a little bit more of amplifier, if you may, but yeah. What do we do? Like, what is this innovative, kind of disruptive or perhaps radical thing that we could consider in driving more resource mobilization? Even for this agenda, we don't want it to be a list of questions that took 1 year to make. How do we, what's in the short term, in the long term, how do we drive investments? Who do we need to speak to?
Isn't that the $1 million question?
I know. Let's start the ball rolling.
but I mean, you really have the right people around the table. It's just, how can we make sure that these issues are mainstreaming in everything else? If WHO is developing a research agenda, that these issues should be part of that research agenda and not as a separate research agenda. If NIH or Canadian government or other research agencies, now I'm just picking names, but if they are investing in COVID-19 research, that should be part and parcel of that research portfolio, not something separate. I think what we really need to do is mainstreaming this thinking into everybody's research proposal, while at the same time we might need kind of dedicated research into issues related to pregnancy, lactation, and so on and so forth, maybe basic science in particular, but it should be really a systematic integration of these aspects anywhere there is research done, analysis done, and really making the data available. I think particularly when there are research done by public funding, I think it's a huge kind of a loss that most of these data by sex, by age, by race, kind of the raw data are not made available or reported. So we are really left in the dark with some of the basic informations around sometimes what data research has been done. You're on mute, Lavanya.
Yes. I was saying thank you very much, Shirin. I'd like to open up the floor now, given that we've got a few minutes left. Perhaps if I can call on Sarah Lynn to speak.
Thank you very much. I'm in transit, so I do apologize for any background noise. Thank you so much for this wonderful presentation, for the extraordinary work that you've done. I put into the chat that I'd like to add personal protective equipment, PPE, into the discussion. I see this as an extraordinarily important public health measure, and it often takes a second sitting to vaccine and other therapeutics, but we know the critical role it will play. We have a publication in the European Medical Journal, which recently came out in August. We have some interviews in the American Medical Association news coming out today. And we focused on PPE, especially the N95 masks, which we know do not fit women's faces, as well as various issues across race and ethnicity. So thank you for mentioning intersectionality. I also want to talk about PPE in the sense of even just gloves and gowns. We've known this back to the days when we were dealing with Ebola and saw that women who were quote unquote on the front lines, often in homes, were getting infected, trying to take care of their loved ones. We're at a critical junction right now, and I don't think we have the time to do the conventional research. We really need to move it into the translational phase. I put an ask out to the highest level of the United States government to consider doing a challenge competition, similar to what we did when I was at the White House during the days of Ebola, where we helped to design new suits, which were very effective in very extreme environments, such as what we saw, for example, in Africa. And I want to put that out to all of you, that we have to think of sort of the less conventional methodology right now, because we're really time strapped. This pandemic is roaring across the globe, and it's going to be with us, and we need our interventions now. So to consider challenge competitions, engage your academic design centers, engage your corporations. I am happy to be part of this. I have a nonprofit called iGiant. It's an acronym for the Impact of Gender and Sex on Innovation Novel Technologies. We are the only nonprofit accelerator for gendered innovation design in the world, and we're happy to help move this forward. I also want to thank Jeanette for mentioning issues regarding boosters. It's certainly a concern, I think, of all of ours, that we know immune systems in women are certainly different than men, and to give the same dosage is a concern, but also the time. What is the appropriate intervention? I hope that as our countries are evaluating the data, that they're actually disaggregating it by age, by race, and sex, and really taking a cohesive view, because again, minimize side effect, provide more vaccine around the globe, and be effective is the key here. So thank you for having an opportunity for me to mention these issues.
Thank you, Sarah. Thank you so much for making time with us, even while in transit. We'd love to take your offer up and have maybe a follow-up conversation about how we can draw upon some of your ideas, innovations. This sounds so fantastic. So perhaps that's a larger conversation. Jeanette and we've been talking about having this roundtable. I mean, it's still in its idea phase. It hasn't happened yet, but perhaps, we can actualize this in the weeks, in the months to come. And perhaps it's an output of this therapeutic and diagnostics groups.
We would be happy to do that. We've hosted roundtables on PPE, and we'd be very happy to work with you to do that. Thank you.
Fantastic. Thank you so much. And I want to open up the floor to everyone else that's here. Is there any other feedback, any other thing that we have missed? Or perhaps you've got suggestions of how we can do better in attracting more people to input into this process? Opening up the floor.
Lavanya, I have a question I'd like to pose to people.
Go for it.
As somebody who has looked at this area for a while, my initial impression is that we just needed data, because people's mind gets changed by data. Now, I really at least know that the vaccine and experience in America, data is not all you need, and that we need translational education, and we need to change cultural ingrained ways of how we do science and how the inclusion of sex and gender are looked at traditionally with mainstream scientists. So it's kind of some of the infodemic issues. And my question to the group is, how do you think we would do, how could we be most successful by bringing in social scientists that help us change behavior? Because if you talk to Kara Tenenbaum in the Canadian Institute of Health and Gender Institute, you realize that when they make structural changes that demand that their researchers include sex and gender, oftentimes the researchers will come up to her later and go, oh my God, who knew? So trying to figure out the difference between the carrot and the stick, but also switching the conversation as to the value to change the cultural history of science research.
And your responses?
I just want to add to what Janet said. I think we also sometimes underestimate the resistance that is out there. You're right, Janet, that sometimes you think, oh, as long as the evidence is there, then people will realize that this is important. Well, when we did kind of a survey early on before the SAGER guidelines, that kind of almost a third of the respondents really did not think this is important or had a resistance to some kind of a policy. And I think we also have to figure out how to deal with that resistance.
Definitely. So I've got a hand raised from Fatma. I'm also conscious that we've got 1 minute left and we will be magically pulled back into plenary. So Fatma, do you have any input? You're on mute. while we get Fatima, we've got Sabine.
Shall I go ahead while we wait?
Yes, please. Thank you.
I hope you can hear my voice well. I think the essential point, and that's a bit of what we've seen with our work lately. I mean, we were also hoping in one way or another, if the data is out there, people will pick it up. But what we're seeing is really that this is not happening. And I must say, we've been most effective in the last month or year or so in trying to liaise early on with our potential stakeholders who could actually make the change happen. So when we came up with the data, we already liaised, let's say, with the EU Commission, with the EU Parliament, in trying to make clear to them, we're going to have data that can back up some kind of potential political decision you're going to make. If you're going to talk about trials, there's the EU regulation on medicines is going to change. We are actually coming up with data that might help you. And, we did this independently, of course, but you are our stakeholders who can push this forward in an arena where we are not going to enter. So I think that part of the work in identifying early on who will be the practice-oriented stakeholders, who will use our data, I think is essential in actually getting the biggest impact. I mean, we're working on implementation, and most of the work we do is actually figuring out early on who is going to use this data for what, and how can we also translate it in a way that it doesn't only appeal to researchers, but that it appeals to the end stakeholders. And I think that part of the process is essential, and possibly also something that might have to come in more here. So do we have to liaise with pharma? Do we have to liaise? Because I mean, they invest the money and they want to make the money. So I mean, of course, we have a critical relationship with them sometimes, but at the end of the day, they're producing the vaccine. So how do we make sure that there is a return for them in this? How can we make clear to them that, if you have more side effects, it's actually a loss of funds for you. So you might want to look into sex differences in the development earlier on, because you're going to lose money. So how do we speak to them in a way that actually makes sense to them and not just to us as researchers? So I think that's the essential aspect of this, and really trying to develop this kind of vision of who are we going to work with, and how can we tailor our results, then maybe bits of it, so that people can actually pick it up and that things will change. That's at least our experience in the last year or so.
Thank you, Sabine. And on that note, in 6 seconds, thank you very much for joining this breakout group, and we'll see you in plenary to continue.